Okay, we're on. I think we're on air, Sandy.
Okay.
Well, I hope people have been able to watch this and tune in. Um, you know, Sandy and my name's Cole for people that don't know me. Sandy and I spend a lot of time coaching ourselves through how to get her PowerPoint onto this, and it was working perfectly the other day. Sandy, unfortunately, it hasn't worked out this afternoon.
Well, it just didn't work. So anyway, we're going to talk anyway because that's what we're good at.
Yeah, that's it. Like you've been known to have a bit of a chat with people. And so what we're going to do, folks, is we're going to have this conversation now. Sandy's going to give us a little bit of an overview of her work. She's going to sort of flick through a few of the slides that she did have ready for us. And then what we're going to do is straight on the back of this, as soon as we're done, we're going to record that slideshow and pop it onto this website, the CoulsonInAustralian.com website. So you will get this actual PowerPoint presentation that she had for us. Just unfortunately, it won't be live for this month. So by February, that's going to give us a whole month to do some coaching on this, Sandy. We're going to nail it.
Yes. Listen, it's not all Sandra. The computer just is not functioning.
Yeah, no, it's just one of those things, unfortunately. Sandy, you've been doing this oral myology gig for a long time. You've been teaching it for a long time, and today we're working on launching some new stuff. We're working on launching some webinars. The technology hasn't always helped us out today, but the cool thing is, I think with the work that you've been doing, you're always pushing the limits, aren't you? You're always pushing boundaries.
I try.
Yeah. And so what we're doing today is kind of like a result of that. And what's going to happen is in the future, we're going to nail it, right?
Yes, we're going to really nail it.
Okay. So in the spirit of that, what could you share with us about essentially what was going to be in that PowerPoint, what you've learned over the last 45 years of doing this, and also what's going to be coming up in the foundation course in Brisbane in April?
Well, let's talk about that course to begin, because the foundation course is really all about what this therapy is, and certainly it's from the Coulson perspective of what I've developed over the years, because most of you know I'm a former speech pathologist, but in my days they were calling us speech therapists, and I didn't find speech therapy working well for me because I just didn't see kids getting over the articulation things that they needed to do, nor any kind of facial muscle functioning that they needed to do to chew and swallow properly. And I'd been in dentistry for quite a while, and I saw a lot of things going on that I felt needed addressing that just weren't addressed in the standard speech therapy that I had been educated in. And so because of my dental background and then my speech path background as well, I wanted to make things hurry up a little faster. And everybody who knows me knows that I like things done yesterday. So I don't like to wait around for things to happen. When I was seeing kiddos that had been in speech therapy for 10 years and they still had this kind of a lisp, thinner than high school, I was very frustrated. So that's why I left that field and started this practice. So this therapy and what I got excited about was it's for abnormal tongue rest posture and all sorts of improper oral habits, which has certainly gotten greater as I've been in this practice longer. I mean, I just saw a little kiddo today who has pulled out most of all of her hair, and they've been through psychiatry, all kinds of drugs, all sorts of things. And I really think that she's going to do well by getting her tongue up and getting some nasal breathing going, which is typical for all of my trichotillomania patients. And I think we're going to see an enormous change with this child. So it's that kind of challenge that I've tried to stand up to, and seeing different kinds of issues. You know, I ran a school for multiply handicapped kiddos for 5 years. So I ran the feeding program, helped to design the PT program and the OT program, as well as speech. So those sorts of things have helped me to sort of hone in on some of the things that I've done over the years. And it's changed my life quite a bit. And I think it's changed the lives of quite a few people.
So traditionally, you know, this webinar is open mouths and low tongues, a positive approach. Like a lot of different professions would have an approach to seeing children and even adults in that position. Sort of, can you share with us some of the things that make your approach, first of all, positive, but what I understand of it too is, you know, it's startlingly simple, really, isn't it?
Well, it is, and I've tried to keep things really simple. What I want to share with you tonight, and what we'll share on the web, is that it doesn't have to be extraordinarily complex. I like to keep things simple so that people understand what they're doing and why. And most people can get a grasp of the fact that their tongue belongs on the roof of their mouth. But that in most cases with people I see, that's not true. And as we begin to use, and I use our little tab on the palate that I actually discovered about 32 years ago and have shared with a lot of people, so that the simplicity of putting something like that in the palate makes things change quite quickly. And simple exercises that are not horribly difficult to do, that are fun, keeps people working on things. Our compliance rate is wonderful, and children come dashing into the office because they're excited. We have very, very small recidivism rates, and I think the reason is because we do keep it simple and we make it fun.
So that's a positive approach. I mean, you know, it's one of the things, getting kids to comply with stuff. And I would say, you know, in terms of how it impacts a child's life, you know, doing the exercises, having the sheets to tick on and all that stuff, it's not exactly a really small ask. Like, you are asking them to commit to quite a lot, right?
Sure. I mean, yeah. I'm after them to perform. That's why when I started this practice, I started taking measurements and photographs as well, so that I could understand what I was doing and if it was making a difference. And then, of course, patients love to get measurements. They want part of the science. Certainly, I don't try to overwhelm them with that, but it's really important that they understand that what they're doing is making changes, not only through the measurements that I take, but the photographs as well. You can really see changes. You see what I have all over my home office here are photographs of befores and afters, and sharing that with people so that they really understand what's possible is great, without making them feel bad on their first appointment, like they have lots of things wrong or whatever. It's really exciting for them to see them get excited about what's possible. When you see lips that are everted or a short upper lip with a gummy smile, most people are wanting to change that sort of thing. And the beauty of this therapy is that it does change those things.
So just in the kids being able to see, oh, look, this is what people have done before, and this is really kind of what's wrong with me, and this lady can obviously, or this therapy can obviously help me get that. Is that enough to keep them motivated, to get them super interested about their tongue?
Well, it is, but I use a lot of incentives too. So, you have to keep people incentivized to practice. But the biggest thing, and what I try to stress, is that they're making improvements for themselves. It's not just to earn a toy, and I do a lot of that kind of thing with kids. But, half of my practice are adults, and I want the adults to be motivated too, and they're motivated by the changes that I can measure and they can see.
So are the adults that are coming motivated, they're not motivated purely by aesthetics, right? What type of cases would you be treating with low tongues and open mouths in an adult?
Well, sometimes they're motivated by the aesthetics of being able to get their lips closed and getting their smile lines to straighten quite a lot. Primarily, they would be referred, because so many adults are doing orthodontics now. They're motivated to get their braces off early, which we find quite often. They're motivated to make certain that this time that they're doing the orthodontics, it will last, because so many of the people I see have already had braces that didn't work. And they might have had them on for quite a while. I had a woman in today who wore headgear for 3 years. And now, of course, what would you suspect? She has some issues with her jaw joints, and she is also a sleep apneic because they removed 4 bicuspids. And it's not always the case, but it certainly does shorten up the space for the tongue to live in. And so they're motivated to see change visually and also to feel it. Most patients who start getting their tongue up experience an enormous difference in jaw joint pain and jaw joint function. And that's pretty exciting for them, especially within 2 or 3 days if they notice a big difference. But I see unusual cases too, which you'll see on the PowerPoint that I prepared for you, because I see a lot of people who've had partial glossectomies. I see people who've had serious accidents. Maybe they've had some sort of paralysis, say from Bell's palsy, any number of those things. And it's amazing what muscles can do to learn new behaviors.
Okay, so let's share with us a few of these secrets. Is it just about telling people to put their tongue up? I mean, for people that don't know your work, how do you actually do this? How do you actually create these results that people have been trying to create for years? Figure out the secrets to this. How do you do it?
It's exercise, exercise, exercise with the muscles of the tongue, the lips, the face, the jaw, head, neck, and body posture, and breathing.
Nice. There's some questions for me. I'm going to ask you another question in a minute, but before I do that, we've got about 30 people watching live at the moment. For those people that are watching, as I said right at the start, if you missed the start, we did have a lot of trouble getting the PowerPoint working on the webinar, so unfortunately we're doing more of a question and answer, and we will present the PowerPoint on the website afterwards. But what I'm wanting to do is maybe make this a little bit interactive. Let's see if we can open it up to some questions from people. So I've got my phone here. And if you're in Australia, my number's 0412 294 216. So 0412 294 216. Text me a question for Sandra Coulson live on air, and we'll see if anyone's brave enough to send us through some questions while Sandy's talking the next 5 or 10 minutes. And what was that, Sandy?
I said be brave.
Be brave, that's it. Text me a question, anything you want to ask Sandy about her methods, about the course, about what oralmology is. Send through some questions, 0412 294 216. If you're watching internationally, that's +61, so your international dialing code, it's 61 for Australia, and then 412 294 216. You got to drop the 0, but in Australia, obviously 0412 294 216. All right, Sandy, speech therapy. There's one. Margin's in, margin's on. Hey, Margin. Speech therapist, Sandy. There might be a lot of speech therapists watching. Okay, how does this kind of therapy, this oralmology, impact on outcomes for speech therapists? I mean, that's a pretty good, critical question, right?
Well, I know there's controversy about whether myofunctional or oral motor exercises make a difference in children being able to change speech patterns and things. I've read some of Dr. Loft's negative comments about oral motor exercises, but I think we proved that to be inconsistent at best and wrong most of the time. I think Chelsea, one of our best little gals there in Australia, could speak to what the changes are since she has started using some of the therapeutic techniques with her kids. She's just raving about the changes that she's getting. Tongue position, especially for TD and NL sounds, kids who've not been able to even get their little tongues up. And we need to talk about ankyloglossia as well at some point, but a lot of those kids are not ankylosed. They don't have tongue tie, but they just don't have good tongue movement. And with this kind of therapy and with getting the tongue into a great space on the palate, I have a tongue, then we know that we can get that tongue to start moving in a different way to produce many, many better sounds. So from a speech standpoint, when I started this, I just saw an enormous change. I was still doing speech therapy. I was working part-time for the Denver Public Schools here in town. And I was using some of my techniques, and it was amazing. Kids who'd been in therapy for quite a while were making incredible strides. So that's what I see as changes. I mean, it's getting the muscles moving properly. I know there are a couple of people in Russia and a gal whom I met not long ago who does a lot of intraoral massage for speech sounds. So I've thought all along it was muscle activity, and I'm just being reinforced by that all the time.
So would you say that doing the oralmology sort of hastens the results of speech?
Totally. Yeah, it depends on what the kiddo's problems are, but certainly from my viewpoint, I get a lot of referrals from speech pathologists here in this city, and it's amazing how the feedback comes back that when the kids are in school or going to the speech pathologist at school or the private speech pathologist, how much quicker those kids are actually finishing up their therapies.
Simple exercise examples.
Yeah, my husband's coaching on the side here saying, can you give some examples? Well, if a child can't lift his tongue, how can you expect him to produce a TDN or L sound? So, everybody who's taken my course knows that and many people around who teach this stuff and do this therapy use tip pops, but they have to be able to be that loud. You can't just have them going and expect any kind of muscle activity to last that's going to be structured so that those muscles are going to work with some changes. I know there's great speculation. I read Dr. Loft's article this morning, as a matter of fact, saying that there is absolutely no research that shows that if you build muscle tone, it makes a difference. Well, I beg to disagree, because I'm a ballerina in background. I'm a gymnast in background. Had I just gone to do either one of those things without doing some kind of muscle activity, I never would have been good at it. And so you can't just walk in and do it. You can't just walk in and do perfect speech either. You have to practice it. You have to make sure that muscle function is there so that production is where it needs to be.
Yeah, but that would be the key point, wouldn't it? I mean, if you're trying to get kids to speak and articulate, you're not winning, but the muscles are dysfunctional, it's kind of like pushing the river, isn't it?
Of course. And, there's been a lot of pushback on that. I'm not sure why, but that may be why this field has not grown as much as it should have over the years. But right now it's growing by leaps and bounds, and it's very exciting.
University of Graz example.
Dick's got a comment again.
Yeah, Dick's.
Well, the research, the Graz.
Well,
research.
we did. Dick wants me to cite the research which you will get in the PowerPoint. When Christoph Moschek and I did some wonderful research, but it was really with adults on arch width change. We proved that you can, through just my therapy and with just my measurements, that you can absolutely expand the arch of an adult, and that's ages 18 to 54 in our study, for at least 3.5 millimeters, and at some point it was 5 millimeters as well. So there are plenty of things, and I just found another study that totally supports our study. Ours was the first ever published showing that tongue muscles can expand the arch form. And now I've just found another study, which I have included on the PowerPoint for you, that you can read, that supports what Christoph and I did.
I also just got a text in from Chelsea Sandy, who you mentioned before.
Yes.
The speech pathologist. And Chelsea says, from my experience, because obviously she's been working with it since July, it helps individual sound production, intelligibility and fluency.
Good.
So it works for many presentations. And she said the work that you're teaching, the myofunctional therapy, is more than traditional oromotor exercises that they're taught at uni, in training. So it's much more than that. And there's also another, well, look, here's a text of support. Sam Foster, a lactation consultant who works with Margin, is attending in April. We're excited to see you, Sam, in April. There's another question from Christine in Sydney, Sam.
Yes.
Which is how much, well, there's a few questions in this actually, but I think the first aspect is really good. How much do you factor in a patient's overall systemic health issues into your treatment strategy for their craniofacial symptomology? So other health factors, and also there's another layer to that question too, which is about diet. Like, nutrition would be one. If they're coming in and they're eating a pile of sugar and everything else, does that affect your outcomes?
Of course it does. I don't use kinesiology, but I do know about it, and I've seen it used with sugar tests, where we know that kids who eat a lot of sugar tend to be less strong. Most of my patients, I'm really fortunate, are pretty aware. The parents are pretty aware. I see a lot of homeschooled kids. I see a lot of kiddos who are really into health themselves. I have a lot of young kids who are vegetarians by their own choice. And so that factors in for sure. But naturally, one of the biggest things I'm looking at is whether they can breathe, because they can't really be successful in the exercise program if they cannot fully breathe. I just had a little guy who had surgery today, and I don't necessarily push that at all, but he had tonsils that were the size of golf balls. And the pediatrician kept saying, don't worry about it, he'll grow into them. Well, the mother finally just pushed, and we finally got him to an ENT. They did the surgery today. She called just a little while ago to say he came through it beautifully, and this kid's life is going to be changed. I saw him 2 or 3 visits and said, I'm stopping. I can't do anymore because this kiddo can't keep his mouth closed, can't keep his tongue up, can't breathe through his nose, is not sleeping well, and was very hyperactive. And I think this is going to change this kiddo's life. So to answer that question, certainly total health is a major issue.
Yeah, I think that answers that question quite well. So in other words, there are definitely other health symptoms that you can recognize that will definitely contribute to successful outcomes, and you have to deal with that before. It's not a fix all. You're never saying that oromology is going to fix everything. You're saying it's part of the complete picture.
Sure, we're a part of a team, and I'm lucky here. I've got a great group of people who, I've got great people who do laser frenectomies. I've got good ENTs who are not just knife happy, but they'll do a tonsillectomy or an adenoidectomy or a turbinectomy if need be. And they don't just put the kids on steroids for 9 months.
I got another fantastic question relate to this as well. So keep these texts coming in, guys. It's working really well. Who needs your PowerPoint, Sandy? This is great. This is so fun. Why were we stressing out?
I don't know, but we were.
Yeah. But anyway, this question from Catherine in Melbourne. She's a speech pathologist, and she sees a lot of kids who have all the stuff we've been talking about: open mouth posture, forward tongue positions, poor oral awareness, and dribbling. Typically, she says these children also have low cognitive function. Do you believe that your exercises are applicable to these, inverted commas, lower functioning children? And do you think that the improvement is due to better oral awareness or also changes to oral tone?
Absolutely. Colin and I have had fun because I started a down baby and mother group about 5 months ago, and I know Colin's doing one as well. But it's I think we're going to change these kids' lives totally. I started at 2-month-olds, and now I'm doing one on tomorrow morning, as a matter of fact. And these moms and babies are just doing phenomenally. The babies are making many more sounds, doing much more activity with their faces and lips and tongues. And some of these parents have had more than one down kiddo, and they're seeing an incredible change in what we're doing with some fun activities with these kiddos starting at 2 months. My first session, I had 9 kids from 2 months to 2 years. And it's shocking how much change they've made. And I'm seeing a lot of those kids independently as well. I think by getting them to nasal breathe, by getting them to have that tongue up and keeping their mouths closed and being able to function in society better as well, we're going to impact their lives incredibly.
Facial changes.
The husband is saying what facial change we see too. So we do see enormous facial change.
I have a comment here from Dr. Margin Jones as well, who's obviously, if you've seen the material, the course information and so forth, she's presenting on the Sunday, the 17th of April, on really understanding tongue restriction. It's her area of, total expertise, which is why she's interested in this work as well. And Catherine also had another part of her question, which I didn't read, but Catherine, this might answer it as well. The second part of the last part of your question, but Margin says when low tongue posture is established as a habit, children and also adults don't realise and know the full capacity of the tongue and its range of movement. Exercise strengthens and tones the muscles, full stop. So facial muscle exercise will increase the capacity of these muscles for all functions. So Sandy, part of Catherine's question was, I guess, is this happening, when you do these exercises consciously, do they basically autonomically take, does that tone translate into autonomic function as well? Margin's essentially saying yes. Would you agree?
Absolutely. And muscles have memories. So once we build neural pathways that are new in the brain, it's amazing, because one of my patients today is the niece of a patient that I had 32 years ago. And she's a cousin of this patient from 32 years ago. And the mom was telling me that this patient of mine formerly has the most fantastic teeth, and they've stayed. She was also a patient of my husband's, which is great. But what happens is, once you establish these new patterns, as long as something major doesn't happen, like an auto accident or some sort of accident to the face, or some sort of neurology that changes, it's amazing how all of these faces really remain as we train them. I see patients very frequently in the grocery store, or as I'm traveling or at meetings that I trained years ago, or I run into parents who tell me, they're older parents now, and they'll say, my son was a patient of yours 25 years ago, and his teeth are still fabulous, and he looks great, and he's still a nasal breather. So, these things, if you establish them well, they stick.
Fantastic. Going back to the whole tongue tie thing, a question from Carly, who's a speech pathologist in Melbourne. In fact, she said she'd love to ask you a question. So, what is the role of oral-facial myology for working with infants and young toddlers after frenectomy for tongue tie? How can we help these little ones to improve tongue range of movement after surgery? Tongue elevation, particularly if we're not seeing much improvement after surgery. There's a good one for you.
Yes. Well, this is where this comes from, is doing tongue mobility exercises. And, I don't know, I know Marjan is giving exercises, but a lot of doctors seem not to be. And I like to see the patients prior to their having their lingual frenectomies and the labials as well, because once we get established some sort of muscle movement and an awareness, then we can do that right after the frenectomy. And I teach parents movement pressures and things down right on either side of the frenum. They're pushing up and back. The patients are doing those sorts of things, keeping that tongue elevated. And eliminating the scarring down that I've seen with so many people who, you know, the doctor just snips with the scissors and says, goodbye, it's done. And then in 6 months, they're experiencing the same things that they had before, which could be an anterior tongue rest posture, or it could be bilateral. And all of a sudden, I think a lot of the reason for orthodontic relapse is that the tongue frenulum has just not been addressed. I see a lot of adults, I send a lot of adults for frenectomies, and many, many of those have experienced failures with their orthodontics.
So I think from the Coulson perspective, your method perspective, before frenectomy and after frenectomy, it's absolutely critical to do this work, right?
It is. It is. And if parents are amenable and if the doctors will refer before they do it, so that in those critical 24 and 48 hours post-surgically, we can keep that tissue stretched. And doing them with laser like Marjan does is just absolutely perfect.
Nice. What about moving to adults now? Actually, we've got one of your states people, Megan from Colorado, text me a question all the way from Colorado. That's pretty cool. She's just interested in how using these techniques, dental hygienists can actually become really more active in kind of management of adult airway issues. So she asked if you can give some examples of how that's possible. So how using orofacial techniques, functional therapy can help with addressing airway issues in adults.
Sure. Goodness, most adults who have airway issues tend to be open mouth breathers. They might be snorers. Certainly, if that's true, the tongue posture is low. And, you know, dental hygienists are primo for being able to really evaluate what a parent's or a patient's tongue is doing. So when they're in there, they need to be looking for short lingual frenulums. They need to be looking at range of motion of the tongue. I know a lot of hygienists complain about how the tongue gets in the way, or a person can't open their mouth very wide to accommodate what the dental hygienist needs to do. And certainly in an airway issue, a lot of the doctors now are using the appliances that move the mandible forward. Had a patient in yesterday, she brought her appliance, and well, she brought 3 appliances because she has one for nighttime that moves her mandible forward, and then she has one to stop the pain in her TM joints in the morning when she gets up after she's worn the appliance overnight. And that was in the form of a jig splint. And then she has another one that's somewhat similar to an Essex appliance, much like Invisalign, that she's supposed to wear during the day to kind of try to keep her teeth apart. I kind of like going to the source myself and seeing if we can't get the muscles to be working properly to begin with, so that if we get the tongue, getting back to my little model, if we get the tongue into a good posture and we get the back of the tongue so that it can actually just maneuver a little bit down, it opens the airway. And on the slide presentation that you're going to have, you will see a before and after of an ICAT that shows the difference in tongue posture and actually illustrates the amount of airway space that's increased just by getting the tongue up, teaching that tongue to rest up, and opening the airway. So hygiene is a prime space for people to be really looking for these things.
Yeah, and that must give them, I'm sure, and particularly if there's anyone who is using this work who is a hygienist and is watching, maybe you could shoot me through a text 0412 294 216 and see if this has been your experience. But doesn't that really open up a lot of scope for job satisfaction for hygienists to really be able to contribute in that way?
Of course, sure. And it's fun. It's fun to help these people.
Well, the exercise are kind of fun too.
Yeah, they're, you know, they're not just sitting around making your tongue rest on the roof of your mouth. We have to be active. And a lot of this, as we do this, I see it changing facial expression. Certainly we're working on posture. And for that, hygienists as well, we need to talk about head and body posture. Certainly forward head posture in hygienists and dentists and people who are working over people. I have a lot of patients who are psychologists who are leaning into their patients every day, and they do minimize their airway. They do drop their jaw. Certainly the mandible is lowered quite a bit as they're leaning forward, and their airway changes. Certainly the chewing process too, and that's something that's so easy for a hygienist to talk with patients about. If they're seeing a lot of posterior caries, very often it means the tongue mobility is not very good. So it's not cleaning those posterior teeth. There are a lot of things hygienists can look for, and then implement some of the exercises too.
Yeah, fantastic. It certainly, it really broadens up that scope of what's possible, I think.
Sure.
You know what, we've had a few speech pathologists write in with questions, but I've actually got one written in with almost like a testimonial, Sandy. So this is an experience from a speech pathologist who's come and taken your course, and in actual fact is coming back to Brisbane to do it again. Maybe it's just because we have so much fun in these courses, I don't know. But maybe some of the information too, Sandy. It's a possibility.
Sure. So let's hear the testimonial.
Yeah, let's, because it's really nice. As a speech pathologist who's trained in the Coulson method, my initial assessments of clients is now so much more detailed, which is enabling me to plan and deliver more effective therapy strategies. So thank you so much. So in other words, learning this stuff has helped to be more, be able to see more in assessment and be more effective in outcome.
Great.
Awesome. Well, we've still got 34 people on, and we've got, I would say, 5 more minutes. Well, it's 35 now. So let's see if we can, I'm going to ask my own question now, but in the meantime, if anyone else has got any more last questions, text them to me, 0412 294 216, and or comments or anything you want Sandra to address, and we'll do it while she's live on air. Okay, but you know, one of my questions would be, and I think you typically get this question too, is about snoring. You know, particularly with the kids, how quickly when they start training the tongue, how does, and also I notice like snorting as well with kids that sort of sit there and do a little bit of that sort of stuff. How quickly does that sort of stuff resolve using myology?
Well, it's amazing. Most often I will get comments from parents saying, you know, before he started this therapy, or she, they were mega snorers, and within 2 weeks' time, very often, they have stopped snoring totally, and they are definitely just really making changes to their breathing pattern. So, you know, a lot of parents don't hear kids snoring, particularly. We fortunately have a lot of campers here in Colorado, and so when they go out and they're tenting or they're all sleeping in a mobile home or a motor home, parents can really hone in on what's going on with their kids' sleeping patterns. And I get a lot of feedback that within a couple of weeks' time, they've stopped snoring. It's tongue posture, it's getting these kids with lips closed, where they might come in like this, and within a couple of weeks' time, their lips are closed, but then we're lengthening the philtrum, we're tightening the lower lip, we're really working on the muscles for chewing and swallowing as well, and they're building that muscle set that allows them to nasal breathe. And of course, we're talking about it a lot too. It's such a big factor.
And so how quickly would those results come in? Like weeks?
Yeah, a couple of weeks, big change. And adults as well. I have a lot of adults who come for snoring therapy, and it's pretty amazing what we get. Yeah.
Fantastic. Well, I'll tell you what, Sandy. Can you remember your last slide from your presentation?
No, it's just I've got so darn many of them. It just says, you know, my philosophy certainly is just do the best possible job that you can with as many people as you can. And that's what my whole philosophy about this school has been, is to train people to help more people.
And I think I've mentioned this before, but you've got that motto, aim to inspire before you expire.
That's right. Strong for me.
Yeah. So I you know, after I'll just speak for myself, because my experience of working with you in your courses, I know I tend to run around and do all the logistics as well, but at the end of the couple of courses I've done with you, I've talked to people and I've said, wouldn't you agree this is in some ways, and this might come across not quite the right way, but it's in some ways it's kind of like a personal development course to do 3 days with you. And I'm not talking about that we all sit around and share stuff. I'm talking about essentially the inspiration that does come from you. So if any of that has come through on this webinar at all to people, if it's come through at all on this little tiny centimeters screen, you know, if you've got that interest there, or you've got a spark that's sort of set off in your head or your heart, when you come to meet Sandra and see her in person and be with her and understand not only what she's done, what she's doing, but who she is and the lessons she can teach you, I don't think you can be anything else but inspired.
Thanks, Colin. Well, it's been a joy to work with you, even though this darn computer stuff wasn't working tonight. And we were both a little, but it's still, I'm glad to be able to share this time with those 34 people who were on. And I thank them for taking the time.
Yeah, and this will be available in replay, so if you're watching in replay, and that's awesome. And also what we'll do next time, we might change the format a bit. We might actually do the slideshow before the webinar, and then we might come on and speak about that live, so then we don't have the hassle. So we do apologise for this being on late, but we really were doing our best.
So sorry, but we'll put it up for you. Colin will do it. He's my go-to guy.
All right. So the last little thing is, if for people who are wanting to register for the course, the early bird rate, we're going to keep that going until Monday, okay? Just on the back of this webinar. So we'll keep that going. It'll be the price will go up about $300 after that. So if you want to get onto the early bird rate, jump online, register online, and you can still get that one. So we're just extending that a little. You know, hey, if there is people watching from the US, it'll be a heck of a good tax deduction to come out and take an Australian course, right?
Join me on the plane.
Yeah, you can sit with Sandy. So coulsoninaustralia.com is the website for registrations. So get those in. If you have any problems with it, use the contact form and that comes through to me, and we'll always sort out any issues. So Sandy, any final words from you?
No, I want to thank you for putting all of this together and for keeping that website as dynamic as it is. And I just thank everybody who took their time to join us tonight. And I hope that you will go to the website and actually see the slides. I put together some pretty valuable slides, I think. So check it out.
Awesome. And the next webinar will be up on, I think it's the 13th of February.
That's right.
So same time. With that one, we'll actually address. It's interesting because I just had a question through from Chelsea about which we might actually, Chelsea, we're going to save that for the next one, because on that webinar on the 13th, we're going to go into how myofunctional therapy, oromology can address breathing, how it can be helped in terms of, you mentioned breathing before, Sandy. And yeah, like as Chelsea just said here, why is it that parents kind of expect, I don't want you to answer this now, but why is it parents expect that oral breathing is normal, you know? So how do we address that stuff? How do we look at it? I'm sure heaps of the speech pathologists watching would be seeing open mouth breathing a lot, you know? And I know it's one of the things, as you know, that I work on quite a bit, but that'll be the topic for next time, the 13th of February. In the meantime, get your early birds in, ask us any questions you want, and we'll catch you next month, hey?
Okay.
Thanks, Sandy.
Thanks, Carl.